As I've been introduced, I'm Dr. Lulu from Muhimbili. I'm coming from the paediatric oncology team, and we are both at Muhimbili and the University and the Muhimbili National Hospital. We are one team and we work together. I really appreciate this opportunity to have a chance to represent the children. Childhood cancer, when you compare it to the adult cancers, a small fraction, and many times the children may get forgotten. And maybe policymakers and decision makers may not prioritize this, because even when they budget, it seems like the children are quite a small part of it, they are minority. But if you look at cost effectiveness, if you cure a 5-year-old child, you have given them a whole life and a chance. Really, you don't know who they will become. And since they are small, even the cost of treatment, when you look at the amount of medicine they use, is quite small. So it really pays to invest in treating children with cancer. So today, it's not easy to talk after renowned artists, people with passion, but I will try. So I will start by talking about the pediatric oncology services at Muhimbili. In short, when I say Muhimbili, this is both the university and the hospital. So annually, we see about 500 new children with cancer, and we take care of children from newborns to 18 and 19 years sometimes, when they present with common childhood cancers like leukemias. So we have children, we have adolescents and young adults in our care. And this is just a fraction of the children who develop cancer in Tanzania. We approximate more than 2,000 children develop cancer annually. And really, things are advancing. Currently, there are other hospitals in Tanzania who are offering care for children with cancer. This is Bugando in the Lake Zone, KCMC in northern Tanzania, but also at various degree in other hospitals in Mbeya, Ifakara, and the other hospitals where so they can offer part of the less intense care for the children so that they can be cared for close to home. So at Muhimbili, we have a multidisciplinary team. We work together with the surgeons, they are COCO team, and we handle them very well. We respect them. We can't work alone. We have the pathologist. We have the radiation oncologist at Ocean Road. We have the radiologist. Essentially, sometimes our role is to coordinate care. We as pediatric oncologists, sometimes we coordinate care. We feel that the patients belong to us, but we really understand alone we cannot do much. So we sometimes have to just coordinate care and offer the other essential care for the children, nutrition and the other supportive care when the surgeons or radiation oncologists, they are taking care of these children. As I said, we are lucky we have access to radiation therapy at Ocean Road Cancer Institute. We know radiation services are quite scarce in Africa. A lot of countries neighboring us don't have these services, and sometimes they are forced to travel and come to Tanzania to get these services. So we really appreciate the team at Ocean Road, Dr. Sikuzani Muya and the rest who take care of the children and are really available when we need to discuss with them. When I say we have a vibrant team, yes, we do. So the team is the most important part when you are doing anything. So at Muhimbili, we have a vibrant team. Just like this photo that was taken from here yesterday, which shows quite our senior faculty, Dr. Mwamtemi. Then we have the fellows, pediatricians who are specializing in pediatric oncology. We have the medical officers, and you can see they are all sitting at ease. We are quite a good team. We work together at ease. And this really improves the care and the quality of life and eventually the outcome of the patients we are looking after. And so in improving care again and building the program, training is very important. I think it is all about e-cancer, is about education, having access to education. So Muhimbili University has established the fellowship training in pediatric hematology and oncology, and it has remarkably increased the number of specialists available to care for the children. So currently, this is a recent photo, and it is majority of these are fellows on training, and these are pediatricians, doctors with experience, but now they are increasing their skills and knowledge, specifically to take care of children with cancer and blood disorders. And we have 9 fellows in place who are completely dedicated to the care of these children. So this makes a lot of difference. And we have some who have already finished and training at home. So before we had the training here, you had to go outside the country and get it trained. And sometimes if you train in Western countries, when you come back, you are lost because you trained in totally different settings. And then coping with resources available back home may be challenging. But the good thing also of training at home, when people are training, there is no brain drain because they are offering services here. But also we get an opportunity to train people from neighboring countries. So we are focusing on Sub-Saharan Africa. So we have people from Malawi, we have from Kenya, from Uganda, from South Sudan, who are training at Muhimbili, and this allows for a network. We hope eventually we can move together as a region, Sub-Saharan Africa, because we share challenges and we share opportunities. So my talk is focusing on decision-making in pediatric oncology. So when we are talking about choosing wisely, it's all about making a decision, a choice. To make it, to choose is to make a decision. You need to have a lot of things to be able to make a decision. And it's a bit different in pediatric oncology or in any field where you care for children. As you know, the child is the patient, but they are not able to make a decision by themselves. You have to talk through the parents. And when it's a decision about a child, in our culture, most of the time, it's not even the mother who makes the decision. It's not even the father sometimes. It's not the grandparents. Then even who can you really call the shots when you have to make a decision can become another discussion on its own. Parents are not sure if really they can make this decision, or they need to discuss with grandparents, or they need to discuss with pastors. So decision making in pediatrics, and particularly in pediatric oncology, can be very challenging. So among the pieces and bits that you have to focus in, so some are provider related. So number one is the expertise of the healthcare providers, the doctors, the nurses, the radiation oncologists, the palliative care specialist, the radiologist, and so forth. So what is the expertise of these people, and the experience and the personal opinion, and all these things come in there when you want to make a decision. What evidence is there that they can use to make a decision? Is this evidence relevant to our setting? Even when you know this is the best option, is it available? Is it accessible? Is it affordable? But is it the best for the family? When we are talking about a child here, somebody presented here, cancer really is not an individual's decision. It's a family, it's a community challenge that a group of people face. So some factors are patient, and I have to put a / parent related because we care for children, so it's really the parent or the caretaker. Sometimes the person who is there with the patient is really not even a close relative. It's somebody who by that time is available, has the time to come and spend their time at the hospital. This can be a week, can be a month, can be 6 months. So it is very difficult. The parents, sometimes even when they love their children, but they are working. And now the financial need for the family has even increased because of the sickness of this child. They may not be able to come and stay with their loved son or daughter. Then somebody who is available. I think in the past it was easy to get people, but nowadays it's quite difficult. Everybody is busy and they are committed to something. Sometimes you find caretakers changing every week or every month. So who would you discuss with? Who makes the decision? So all these affects the decision making in pediatrics, and particularly when it's pediatric oncology. So the patient, what are their level of knowledge? When we talk about informed consent, we want the patients, the parents, to own their decision. But are they able? I mean, oncology is so complex. When every time we sit in the tumor boards, the same thing, how we go into this deep, long discussion to come up to a conclusion. How is this parent who is a standard 4 or standard 7 dropout is able to make the choice between immunotherapy, radiation therapy, or waiting, things like that? So how do we really engage parents and that they are able to make these informed decisions? And we forced sometimes to make a decision for them? Don't we sometimes say, let's narrow out and tell them only what is available? Don't we sometimes feel that we cannot explain to them and make them understand? Okay, so that the exposure, the knowledge, most of our patients we see sometimes they're coming from the rural areas. They don't know much. They came to Dar es Salaam for the first time because of the illness of their children. But sometimes we are faced with well-educated patients with exposure who have searched the internet, and they draw us out of our comfort zones because now they are challenging us and we are not used to. And sometimes we feel that these parents are quite troublesome. So the available social support to the parents or to this family also matters in decision making. So I will give one example. When we were, some years we were not treating patients with acute myeloid leukemia, and mainly because it was the challenge of supportive care. So this is an intense chemotherapy, and we felt that the supportive care we had to support these patients was not enough. But later on, we evaluated ourselves and we thought, oh, we are better off. We have now a bigger team. We have an ICU at our disposal at Muhimbili. We think the blood transfusion services have improved and many other things. So we decided, I think it's time to start treating children with acute myeloid leukemia. And then we had to sit as a unit and think, how do we approach this? Because when you are starting, you can't treat everyone at once. So how do we select which group of patients to start with? And issues of social support came up. So these patients will need blood products, particularly in their first months of treatment. So maybe we take patients who have relatives in Dar es Salaam. But can you really justify this option? Can you leave somebody who, because you tell them, because you are from up country, sometimes you need to bring in relatives to donate blood to support your child treatment. So the available social support also matters when you are making decision. And this available social support can be a very long treatment, and the parents say we cannot stay in Dar es Salaam. It's the rain season, we need to go back home and cultivate. So if they have somebody who can take care of the child in Dar es Salaam, then maybe you and the family are able to choose a specific treatment plan. Now the decision powers I already discussed about. Who really makes the decision about a child's treatment, whether to stop treatment, whether to pursue a more intensive treatment. So it's quite difficult and it is complex when it is children, I think, rather than when it is adults. So we go to the usual, the policies and the guidelines. I think this was discussed already. They are the guidelines, they are the policies. And so in pediatric oncology, most of the time, if you go in well-established pediatric oncology services, children are treated in clinical trials. Every time there is a question to answer, whether to intensify treatment or to reduce the treatment, whether to replace some kind of chemotherapy agent with the other. So the treatment protocol in pediatric oncology are very dynamic. So it depends which one you have, and we need to adopt them because some we cannot really follow them on dot due to supportive care and other things. Again, what services is available, is accessible, and the financial support, health insurance. Now it has become for everything people ask. So it's when we are introducing patients, it's 6 years old from where, and then they say they have national health insurance cover, because we cannot run away from the fact that money becomes a very important component in decision making and in choosing wisely. So I think the money, So when you are talking about choosing wisely, financial toxicity, there are so many other things to consider when we are choosing wisely apart from money. And I will go and discuss these ones, particularly when it is a child involved. So money, yes, but there are other things that are important to consider when we want to choose wisely for the benefit of the patient and then of the family when we are talking about the children. I believe even when we are talking about adults. So among the other things, these are our doctors. So pediatricians are also parents. So this is our fellows. So both of them, they are holding, these are not their children, these are the patients. You can easily realize that they are quite an emotional bond that is there. You cannot avoid it. I think nature makes adults compelled to take care of the young ones. And this is how the species can thrive. Because biologically the species has to thrive. So we are compelled, so we are attracted, we feel protective of the children. And as pediatricians or doctors who take care of the children, sometimes we have to stand up against the parents to ensure the welfare of the child. You know, sometimes I really get mixed up with parents who bring children and they abscond care and they come back the second, the third time, and I say, if this was an adult, this would be the end. But it's the child who did not have a mandate to make a decision for themselves. So we have to go on and try to find the best way. So when we are making decisions about the patients, and if we are so much close to the real patients, are we able to let the families make a decision, or sometimes we find ourselves making the decision that we personally feel that this is the best for this child? So this is among the challenges we face as pediatric oncologists or doctors who care, and the nurses, I believe, and all other expertise who care for children are forced to decide. Are we able to say this is enough, or sometimes we are forced to let's try it because this child is so sweet. Sometimes you say, oh, but I can't do this. Let's just give this a try. Even though the evidence in front of us, even though the past experience speaks bad, and if you say, but, oh, let's just try. So, and when you are trying, it means you are keeping the patient longer, you are keeping the family longer. Even if the parents don't pay out of their pocket, there is always cost. So treatment is never free. So there is always a cost. Somebody covers that the cost. So could these finances have been directed to care for somebody else whose outcome would be better? So sometimes we like to present it even at families when they sit. They have to choose sometimes who to send to school. When you have limited finances, the family will have to decide. If you have 4 children, you can only afford to send one to secondary school. The families will have to make wise decisions. So us as well, we need to make wise decisions and consider not only the money, as I said, the time the parents they spend at the hospital and how much do they have to lose on this. But also we have to consider the resources that we invest in this particular patient may be a stage 4 neuroblastoma versus if these same resources would go to treat a child with Burkitt's lymphoma. And we also have to consider not only the money, but the toll and the burden it causes to the healthcare providers. So if you have very sick children in the ward, just 4, they will take the care. So they will draw the care of the nurses and the doctors to these 4 children and indirectly compromise the care of much stable children who had a higher chance of cure, probably. So we have, but also the labs can get overwhelmed. But even the radiology, all the imaging that we request, the CT scan, the ultrasounds, from our services, from our needs pediatric oncology, do other people indirectly, do we deny care or limit the care to the other patients at the hospital? So we also face these things that is statistics with the patient at the bedside. So you have a patient at the bedside and their statistics, it tells you that a stage 4 child with neuroblastoma or child with severe malnutrition, increased chemotherapy toxicity and many other things. Then you can, if you look at the statistics, you may say it is not worth it. But sometimes at the particular patient at the bedside, it makes a huge difference. So I have this picture of this patient, and this is not when they just presented, she was already much better. Initially, she couldn't even look around. She was in total apathy, very sick. You know, look at this patient, you say, oh my God, should we really invest our time and try? But this is the same patient who quite looks beautiful and is playing. So whether we are curing this child or if we are not curing this child, it's obviously we gave this child a life for some time, for a year, for 6 months, but it's a good quality of life for this child that we have offered because we are willing to invest time and money for chemotherapy and other things to treat this child. So these are the other things that can you make, and these things make following guidelines. Sometimes people divert to guidelines because we point you remember that patient. Yeah, and all these are valid factors when we are making decisions. Do you remember that patient? But on the other side as well, parents, statistics can come against us, and this is when most of our patients come late, and somebody said, the previous presenter said that people think Ocean Road kills patients, that Mionzi inachoma. So this is tough. Even us, where we have, like when we are treating patients with acute lymphoblastic leukemia, and relapses later on are high. So when the patients come, by the time they are on the second year of treatment, they've seen the patients who were ahead of them coming back with the disease, and they come to you, doctor, and say, but doctor, they start mentioning names. You have numbers, they have the names. They say, doctor, when I started here, do you remember A? Now she's back. Do you remember D? Now, so is really my child going to get cured? So we have the statistics, the patients have the real life, and the names that they know, and they can tell you what happened to them. So these are also among the things that they can affect the decision. So the patient can decide to say, oh, I think I don't need to continue the treatment. Maybe I go home and enjoy the life with my child now, because those who I was looking at as examples, I see now they are coming back. So lastly, from the tumor body to the patient. So we normally sit there, discuss patients, a lot of us, and we go into a long discussion. Eventually we come to an agreement. There is the next step of taking this sometimes half an hour, 45-minute discussion on one patient to present it to the family, to present it to the parent, the father or the mother, so that they can understand and be able to choose, make a decision which way to go. So here as well, a lot of things happen in between. Even documenting all this discussion is difficult. Now somebody has to sit and convey this information. So should we put parents in the tumor boards so that they can get first-hand information? I know the adults maybe do. And when we call them to ask questions. We ask them questions, and then we ask, do you have a question? Of the things that they didn't understand. Most of the time it was in English and it was in medical terminology. So the parents or the patients cannot really engage meaningful to our discussions. So I will finish up with case discussion. So the value of palliation, like I've presented a patient. So when we are talking about, still even in pediatrics, most of our patients come with advanced disease. For children, it may not be, they've stayed for a long time. Most of childhood cancers are quite aggressive, so they come with advanced disease. And you have a good number of patients that we have to palliate them. So when you are talking about palliation, so you have many options. You can cancel them and send them home or nothing, care close to home. Or you can offer them chemotherapy, sometimes maybe less intense chemotherapy protocol, which will improve the quality of life, but it means the parents may need to stay at hospital. And this is a mother with a 80 years old with other children at home, and they tell you, doctor, I have children at home, some old, I've left my children being taking care about themselves. They are the husbands as well who need to be cared for. There are so many things people present. So do you choose to take care of a child at the cost of the whole family? Yeah, so they stay 6 months at Muhimbili while everything else stops at the family level, or what do you choose? Are the parents, and the parents get this guilty feeling when you tell a mother, so they will focus at the sick one. Yeah, because they will feel guilty if they go home and the child dies. Maybe if they stayed and took care of their child, things would be different. We doctors as well, we feel the same guilt. We don't want to be the one who decided. Yeah, so we let the families decide, even though we are not able to really explain and make sure that they've understood the concept. And we have cases about these patients to make a decision. But the challenge, the biggest challenge we have as well, when we have older kids, teenagers, even 18 years old. So in our culture, when these patients are palliative, the parents will not allow you to tell the children. So even if they are 16 years old, even if they are 17, they say, doctor, please, don't let my son know that he is terminal. Don't let him know that we cannot cure him. So then you are in this scenario where you have to present, when you are on the bedside, like the patient is getting cured, and sometimes they understand English. Well, you would wish, and they ask you questions sometimes. So it becomes very challenging when the parents, and we cannot do it against the parents. And I have one example once when I was counseling the parent of this big, I think he's 17 years old with osteosarcoma, huge tumor, I mean, he could not move. And then we had to send the patient back. And then the parent said, you cannot tell my son, I will sort it myself. And I was interested to know, what are you going to tell him? That you have come here for treatment, now you are taking him home without a treatment. Then he said, doctor, I will tell him we are supposed to pay and we don't have any money, so we are going home to look for some money. And I was shocked. I said, no. So you are going to tell him this hospital and this country and this government allowed him to go home without treatment so that you can look for money. So, and I realized sometimes when parents choose their own way, sometimes they come with different coping mechanisms. For this father, was simple to tell his son that we are going home because we are supposed to pay some money here. Let's go home, we are going to find some money and we'll come back. And he was sure in looking for the money, this patient will eventually do what? Pass away. But I mean, this, how horrible it would be for this 17 years old to know that the whole team at Muhimbili could not find a way to really take care of this patient just because of financial problems. So these are major challenges in our setting. Who makes the decision? What is the role of these older teenagers, young adults, in deciding what treatment, what course of treatment to be taken for their own lives? So 17 years old in these countries can be mothers, but when they are sick, they are denied the information to know what is the fate of their lives. So I think I would end up there, and I would close by saying, yes, choosing wisely is complicated, but it is even more complex when it's a child that is involved. And we appreciate this discussion because really it's a valid and a day-to-day decision we have to make. Every time we have to choose, but we will try to choose wisely. Thank you very much for listening to me.